Good afternoon, everyone. My name is Joanne Lee from Purdue University. Today, I will present a zero-shot framework for full cycle for the cardiac Cine MRI segmentation using a medical video foundation model. The central idea is simple. Rather than asking one cardiac phase to represent the entire beating heart, we use end diastole and end systole as complementary anchors to recover the full cardiac cycle. I don't have anything to disclosure. So first, let's start from some background. Cine cardiac MRI is fundamentally a time-resolved imaging modality. Rather than acquiring one static image, it captures the heart throughout an entire cardiac cycle, commonly using approximately 20 to 30 temporal frames. The ventricles contract from end diastole to end systole and then relax and refill. Cine CMR therefore contains not only anatomical information, but also information about cardiac motion and function. However, despite acquiring the entire cardiac cycle, conventional analysis usually focuses on only two frames, ED and ES. Conventional Cine analysis is generally performed at end diastole and end systole. These two phases provide clinically important measurements such as end diastolic volume, end systolic volume, stroke volume, and ejection fraction. However, the intermediate cardiac phases remain largely unused. With segmentation across the full cycle, we can recover continuous volume time curves and characterize dynamic ventricular emptying and filling. In other words, the scanner acquires a movie, but most analyses use only two snapshots. The reason is not that the intermediate frames are unimportant. The problem is that reliable full cycle segmentation remains difficult. So why do we not simply segment every frame? Full cycle segmentation is limited by annotation burden and phase mismatch, unfortunately. For annotation burden, annotating a complete 20 to 30 frame Cine sequence across multiple slices requires substantially more frame-level masks than conventional ED and ES annotation. For phase mismatch, cardiac anatomy changes substantially between the relaxed geometry at end diastole and the contract geometry at end systole. A model initialized at only one phase may therefore fail when representing the opposite extreme of the cardiac cycle. Importantly, our data do not support a claim that error monotonically increased with temporal distance. The supported failure mode is phase mismatch between the two cardiac extremes. This leads directly to our research question. So, can the two clinical available ED and ES annotations be used to recover reliable segmentation throughout the cardiac cycle without cardiac-specific training? Our hypothesis is that ED and ES provide complementary anatomical references. ED represents the relaxed ventricular geometry, while ES represents the contract geometry. By anchoring the model at both phases, we aim to retain the annotation burden of standard ED-ES workflows while recovering dense masks across the complete cycle. To test this hypothesis, we designed a dual-anchored propagation strategy. The proposed strategy used two independent propagation branches. MATSEM2 is first prompted at end diastole and propagates through the sequence. A second branch is independently prompted at end systole and propagate in the opposite direction, including the wraparound portion of the cycle. The final segmentation is selected using the temporal midpoint merge. The ED branch represents the ED dominant portion of the cycle, and the ES branch represents the ES dominant portion. The model is therefore not required to use a single cardiac phase to represent both extremes of ventricular motion. This dual anchor design is embedded into the following full pipeline. So here is a complete workflow. Each short axis Cine volume is preprocessed slice by slice as a 2D plus time sequence. From the available ED and ES manual masks, we derive bounding box prompts for the right ventricle, myocardium, and left ventricle. These prompts initialize two independent MATSEM2 propagation passes their directions are merged at the temporal midpoint to obtain dense masks throughout the cycle. The resulting LV cavity masks are then converted into volume time curves and dynamic functional biomarkers. No cardiac-specific training, fine-tuning, test time adaptation, or morphological post-processing is used. We evaluate both segmentation accuracy and the functional information enabled by these full-cycle masks. So we evaluate the method on ACDC, which contains 100 Cine CMR studies balanced across 5 diagnostic groups. Segmentation performance was evaluated on a stratified 20-subject subset with 4 subjects from each pathologic group. Because ACDC provides manual segmentations only at ED and ES, quantitative depth and surface distance metrics were evaluated at those annotated phases. Full cycle functional analysis was conducted across all 100 subjects using the automatic propagate masks. This component is exploratory because full cycle expert contours are not available in ACDC. Our primary comparison is dual-anchored versus single-anchored MATSM2 under the same zero-shot setting. With this design in place, we now turn to the main result. So the proposed dual-anchored MATSM2 achieved DICE scores of 0.85 for the right ventricle, 0.81 for myocardium, and 0.84 for the left ventricle. Its strongest improvement was in boundary X-ray accuracy. HD95 and ASSD were consistently lower than the single-anchor MATSM2 variants across the 3 structures. The right ventricular result is particularly notable. The zero-shot dual-anchored method achieved the highest RV DICE among the evaluated methods. For myocardium and LV, the supervised UNET remains stronger, which is an important and expected advantage of task-specific supervision. Our claim is therefore not that zero-shot propagation universally replaced supervised segmentation, but that dual-anchoring potentially strengthens a foundation model approach without cardiac-specific training. The overall magnitude of that boundary improvement is summarized in the next slides. Here, this is the main quantitative result I would like you to remember. When averaged across the right ventricle, myocardium, and left ventricle, dual anchoring reduced the mean HD95 from 6.949 to 3.17 millimeters, corresponding to a 51% reduction. Mean ASSD decreased from 1.89 to 0.71 millimeters, corresponding to a 62% reduction. For this calculation, the single anchor baseline is averaged of ED anchored and ES anchored MATSM2 propagation. The model backbone and the zero-shot setting remain unchanged. The only change is the use of 2 clinically defined anchors. The following right ventricular case illustrates what this improvement can look like in the practice. So here, this figure shows an illustrative failure case from patient 99. On the identical end systolic frame, an ED anchored propagation carries an erroneous right ventricular region into the contract phase, resulting in a DICE score of 0.32 in this case, which is really bad. With dual anchoring, the end systolic anatomy is supported by the ES branch, and the DICE improves to 0.95 on the same frame. I want to emphasize that this is an illustrative case rather than the cohort average change. The cohort level result is reflected by the substantial reduction in RV, HD95, and ASSD. Beyond this individual case, the method also produced dense masks across unlabeled intermediate phases. So these examples show segmentation across multiple cardiac phase and pathology group. The highlighted ED and ES columns are the manually annotated anchor phases. The intermediate columns contain model predictions without manual full cycle reference masks. Visually, the proposed method maintains coherent right ventricular myocardial and left ventricular contours through contraction and relaxation. Because ACTC does not provide full cycle reference annotations, this figure demonstrates qualitative temporal continuity rather than quantitative intermediate frame accuracy. The practical value of these intermediate masks become clearer when they are converted into ventricular volume curves. So we next converted the full cycle LV cavity masks into patient level volume time curves across all 100 ACDC subjects. The group level trajectories show distinct pattern across the 5 diagnostic groups. DCM exhibits substantially elevated ventricular volumes with a relatively shallow systolic decrease, whereas HCM shows a smaller cavity and a steeper reduction towards minimum volume. These curves demonstrate that the output is not only a set of segmentation masks, it can be transformed into a dynamic representation of ventricular contraction and filling throughout the cardiac cycle. This remains an exploratory analysis based on automatic full cycle segmentations. For the same trajectories, we can derive the functional measurements that are unavailable from 2 frames alone. So here, from the volume time curves, we derive the peak ejection rate, peak filling rate, time to minimum volume, and stroke volume. PER and PFR describe the maximum frame-wise rates of ventricular empty and filling, while TMS describes the normalized cardiac phase at which minimum LV volume occurs. These 3 measures require a full temporal trajectory. Stroke volume is included as a conventional reference measurement. In this exploratory analysis, DCM showed lower PER and PFR than normal controls, consistent with reduced systolic emptying and impaired filling. These values were derived from automatic segmentations and require validation against expert full cycle contours before clinical interpretation. And together, these findings lead to 3 take-home messages. So in conclusion, we developed a zero-shot door-anchored framework for full-cycle cardiac Cine MR segmentation. The method uses the clinical defined end-diastolic and end-systolic phases as complementary prompts for a medical video foundation model without cardiac-specific training, fine-tuning, or test time adaptation. Compared with single-anchor propagation using the same MetaSM2 backbone, dual anchoring reduced mean HD95 by 51% and mean ASSD by 62% across the right ventricular myocardium and left ventricle. This demonstrates that the improvement arises from the anchoring strategy rather than from a different model architecture. Importantly, the resulting full cycle masks extended Cine analysis beyond conventional ED and ES measurements. They enable continuous LV volume time curves and dynamic measures of ventricular ejection filling and systolic timing. The central message is that rather than asking one cardiac phase to represent the entire heartbeat, we anchor the model at both anatomical extremes. Thank you so much for your attention and welcome to scan the code of the paper and scan the code to connect and further discuss this interesting project. Thank you very much.